so
Right.
if you're 40 degrees above and 40 degrees below, granted some of those are going to be blocked by the lid probably, but you're going to, in general, the foot plates of the ICL are not going to be outside of that. That's nice, especially if you're putting in a spherical lens.
Yeah.
Then if you know there's a ciliary body cyst at 7 degrees, well then, or 15 degrees where it would sit, you know that you can then rotate the lens a little bit, 5-10 degrees, and then that foot plate that usually sits at 15 degrees is now up at 20 degrees out of the way. So that's the main reason for the scout scan. The second bit, the nomogram scan, the reason that we do a lot right around the horizontal meridian is because we're trying to work on a nomogram, and the nomogram has to always come from as close to the 180 as possible, because you've got to because these lenses go in at all different angles. That's all going to come out in the wash if you're measuring everybody preoperatively at 180. And then as Andy mentioned, because there are some differences in the ciliary body, like the little fingers that come out, we want to make sure that we're not, by going up and down a few degrees, we're trying to find where most of the scans look like they line up. And then if there's an outlier where there's one little, I don't know what you call them, like phalange coming out of the ciliary body, you don't want to count that one, because that might be a finger that's sticking out a little bit further than the actual ciliary body, the mass of it.
Okay.
So those are the reasons for the 2 scan sets.
Okay, because we saw a reference to a scout scan, and we didn't.
So we just call the scout scan. We call the scout scan our looking for ciliary body cysts and kind of weird stuff, and then the nomogram scan would be get as many good ones around the 180 as possible, and then have a look and get an idea of what you're actually.
Okay. Perfect. That makes it. I guess this is Ryan. I've not met you, Ryan. Makes it perfect and clear. Another American in London, for heaven's sakes.
Does the team in Denver have any questions so far? Sorry, we got a bit off topic.
No. Nope.
Okay. So for the then if we go down to the next, which is the pre-op scan review. So I'm just gonna open a. Perfect. So if I can just talk you through that, there's some things to point out that are good and bad on this scan. That's why I used it. So if you look at the image below, and this is what Tarek had referenced to, if you have a patient that is not very cooperative, and it's not that difficult for them to just kind of be looking around, even though you're telling them to look at that light. And so if that scan, the technician or whoever's going to be doing it, they've got to look at that little eye image off the side and make sure that when you're evaluating the scans, or like if one of your ODs are evaluating the scans, they've got to make sure that that eye image, that horizontal line is going through the center of the pupil. So that's just a little point. So, if you have it like, right, if the scan was done and that was here, the pupil is going to be tiny in the scan and not, it's going to throw everything off. But so you want to make sure that it's around the center, right? The other thing that we look for is, if you look at number 3 on the screen, which is clear ankle anatomy. And this is important if you're going to be adding different measurements to your scan, like angle to angle, if you're going to use, because there's a couple nomograms that use angle to angle. And when they mean angle to angle, they mean like as far down into the recess as you can get angle. So, nice thing about the Insight is that because of the resolution is so good, you can really see where that iris hits. And there's this little tiny bit kind of hanging out down here, which could very easily go miss in a handheld UBM where the resolution isn't good. So, who's ever looking at the scans afterwards, you want to make sure that the angle anatomy is not blurry at all. If we jump over to number 5, clear differentiation between the posterior iris and the ciliary body. This is important if you're measuring, if you're doing the sulcus, because it's very easy to get some of these scans where the ciliary body is pushed right up against the back of the iris. And so it's difficult to tell where the true sulcus is. Now, I mean, one identifier is the posterior, the pigmented iris epithelium, right, on the posterior. So when in doubt, that's probably a good identifier. But really, you want to pick a scan to put the measurement, the calipers on. You want to find one where there's a nice space between the ciliary body and the posterior iris epithelium. And that'll give you a nice, clear picture of the sulcus. And again, you can scroll through. That's why we do a few, because sometimes the ciliary body will be pushed up against the back of the iris, and it's a bit difficult to figure out where one ends and the other begins. And then the last one on this isn't one of the numbers, but if you look to the left screen here, how this lens kind of comes down and then the arc changes here, kind of flattens out. So that if you see that, that means there was eye movement, and you can see that in the cornea, but you can also find that pretty easily in the front surface of the lens. And so you want to look for that. So if there's eye movement that's going to affect the horizontal measurement, then you obviously don't want to pick that scan to put the calipers on. So that's an easy spot to look for a poor quality scan, or the patient moves a bit during it. Does that all make sense?
Yeah, Ryan, just one thing on that comment is sometimes the zonules will insert on the anterior capsule surface tangentially. So it's also could be sometimes that what happens is seamlessly the reflection from capsule to zonule, you can't tell where capsule ends and zonule begins. And we're doing some more imaging with rotated eyes looking into the side of the scleral wall. And then you can see that more clearly, because you could be right, but then you'd also see some smearing of the posterior pigment layer on the iris as well. So
yeah, you might. And if you look like on this scan on the cornea, you can kind of get a sense there's a little bit of a tweak there where Tarek's moving that across. So it's difficult, but again, that's why if you have a bunch of scans to look at from close to the horizontal, you can kind of figure out if these are real or not.
Yeah, okay, good point.
Okay, so that's just, what I look for. Those are some of the points that I look for when I'm looking through us putting the calipers on for the scans that we're actually going to be using for lens sizing. The next would be caliper placement. I'm going to just switch positions with Tarek here and just take over the mouse. So this is actually one of our most difficult patients as far as knowing what size lens to implant. So I thought it would be a good one to put the calipers on. So for sulcus-to-sulcus, sorry, it's just stuff. So one thing you can do is you can adjust the brightness and the contrast. And this is going to be to help you just to identify the different anatomical endpoints. So for us, we basically have done a shotgun approach, which is like measure everything under the sun and see what happens. And we found that there are a few that are important. So depending on the nomograms that you're going to be looking at or the sizing methods that you're going to use, or what you want to do in the future for your own nomogram development would determine what you want to do. So I mean, you can measure anything you want. The most important ones anatomically for when we're picking a lens would be sulcus-to-sulcus, ciliary body to ciliary body, and then the sulcus-to-sulcus lens rod. So for the sulcus, again, so you can see, like if you're looking here, it's difficult to tell, does it end like, on this side it's pretty clear. I would go all the way to here. But over here, you can make an argument that it ended here, or you can make an argument maybe the ciliary body is just pressing and it actually ends here. So there is a bit of experience, once you've done a bunch of these scans, you'll get a better idea of where to put this. But let's say we put it here. We're going to go from sulcus to sulcus. For right now, the best two nomograms to use would be the Kojima one. Dr. Kim, I'll send you the papers. The Kojima paper and the Doherty paper. So for Doherty, they use sulcus-to-sulcus and lens power. So the sulcus-to-sulcus measurement is something you want to take on every single patient. And then the Kojima paper, they also add a sulcus-to-sulcus lens rod. So you take the sulcus plane, which we just have done, and then we're going to measure from the sulcus plane to the anterior lens capsule, and that's considered the sulcus-to-sulcus lens rod. In their paper, it's abbreviated SESL, and then he uses the ATD as well. So for sulcus, again, usually what you'll find is the ciliary body kind of comes together at the posterior pigmented iris epithelium. And at the end of that hyperreflectivity is, for most patients, what you're going to pick out for sulcus-to-sulcus. Does that make sense?
Yes.
Okay. Let me just pull up another one. So this is what we were doing. So
Ryan, while you're clicking through images, just something to answer for us a little bit later. Are you generally doing dilate? Because I see some eyes that look like they're dilated and others that are not. Just what your preference is and why.
So it must be done undilated. Because dilation is going to move the ciliary body out of its normal anatomical position. So the patient cannot be dilated on the day that they have the ICL. So the insight.
But it does look like there's quite a bit of variation. It's one of our challenges is everyone's eye reacts to light inside the instrument differently. So when you're undilated, particularly a very active iris, it can change during imaging. Actually, you can see it the iris moving, so I was just kind of curious. I understand dilation moves things, so.
Yeah, it's not enough. They're gonna be dark enough where they're not, really to move the ciliary body, the pupil has to be in bright, but like 40 lux of light to be able to move it, small enough to where you're going to get big ciliary body shifts. So to us, there's nothing to control the lighting. So to us, it's just, you put them in and, in young patients, you're going to get a big pupil, and in older patients, you're not going to get it quite so big.
Yeah, okay.
That's really all you can do for now.
Yeah, okay. And do you try to adjust the light level of fixation at all to make it better or worse, or you just kind of set a nominal, medium level light?
We just leave it go.
Okay.
So you can see Dr. Kim and Greg. This is what we were doing. So we're putting a ton of measurements on every eye. So we're going. So you can see this one here is sulcus-to-sulcus. We have ciliary body inner diameter. So ciliary body to ciliary body. The other thing you can do for now, because these all get confusing, is what you can do is, you take the measurement, if you're going to do angle to angle, say, so it's 11.691, and the guys from ArcScan can, if there's a better solution. So what I'll do is I'll just 11.691 goes there. That's one of the lesser important things. So I'll just, go like, and then that's there for me later if I need it. Because the important ones that you want to have on the scan are going to be sulcus-to-sulcus, sulcus-to-sulcus lens rod, and ciliary body to ciliary body. Right now, there's nothing that we could find that showed that you would change the lens sizing based on angle. But we do it on every patient anyway because, it's more about a safety factor. So if someone has a preoperative angle of 15.
Can you show us again how you measure the angle?
So you go here.
Okay.
And then we'll go here, and then you just click again, and here, and then you can move this.
Thank you.
So we use it just as a safety measure because we've had some patients that have had, shallower APDs or like maybe a angle of 20 to start, and then you're worried if you put in a lens that's too big, it's just going to shut that angle down. So, we use it to monitor safety post-operatively right now. And we'll see if that ever kind of gets put into a nomogram. Right now, it didn't make a difference, but who knows in the future. But it's nice to have pre and post-op and track how that's going for your record.
Great, thank you.
So the caliper placement it's important, but it takes a bit of kind of playing around to figure out exactly. And some of the scans, like this scan, for example, I'm not going to put any calipers on the scan because I don't know where this starts and stops, right? So this is an example where the ciliary body is right up against the iris, and I just can't. I'm not comfortable putting, because it doesn't end. This is not it. All right, it's probably out here and out here somewhere. Right, so that's what you've got to look at scans like this, where you just got to throw them out. And again, some of that comes with experience. Some of it is pretty straightforward. Like on this one, you just can't tell, no matter what you do, where the anatomy changeover is. So I wouldn't use that.
So Ryan?
Yep.
So let's say you find a fantastic scan, and you feel really good about where you're putting your measurements,
Yes.
then are you trying to, like, do you trust that one, or are you trying to then find several more that are excellent and then taking the average of those 4, let's say?
So we're doing averages right now. We had a conversation about that because mathematically, averages aren't always the best thing when you're trying to do a nomogram. But right now, because there is some variation, you know, the ciliary, it would be easy if it was like, you know, LASIK, where the laser is going to reshape the cornea the same way when you put in a -4 prescription, right? But because there's some variation in how the ciliary body sits and how it looks, and kind of creases and where the ciliary body might come into the form the sulcus. So we are doing averages and kind of throwing out the jump